I want you to imagine your body's stress alarm. You know, the one that gives you that sudden, massive burst of energy to flee danger or to fight for your life.
Right, the classic fight or flight response.
Exactly. But now imagine that alarm gets stuck in the on position. And not just for a few minutes or even a few hours, but for months.
Or even years, yeah.
Right. Years. What breaks down first? That is exactly what we're unpacking today in this deep dive. We are exploring the pathophysiology of Cushing's syndrome.
Which is such a fascinating topic.
It really is. Our mission here is to figure out exactly what happens to the human body when it is just chronically flooded with cortisol, which is, our primary stress hormone.
And I think it's important to note that the stakes here are so much higher than you might initially think.
How so?
Well, because what started out, nearly a century ago, as a story about these very rare exotic brain tumors, it has completely shifted. Today, this is a massive everyday public health issue. Yeah. And the real irony is that it's largely driven by modern medicine itself. Like, we are seeing this physiological cascade play out in millions of people globally right now.
That is wild. Okay, well, before we even get into what cortisol actually does to you, I feel like we need to clear up a major misconception about the condition itself.
Oh, the naming issue.
Yes, it's a naming issue that apparently trips up, medical students everywhere. I'm talking about the difference between Cushing's syndrome and Cushing's disease.
Right.
Why do we have two names that sound like the exact same thing?
They definitely sound interchangeable, I'll give you that. But that distinction matters enormously in medicine. So Cushing syndrome is the umbrella term.
Okay.
It basically describes the entire clinical state,
Right.
The whole picture of the body's response to having way too much cortisol, totally regardless of where that cortisol is coming from.
Got it. So that's the syndrome.
Right. Now, Cushing's disease, on the other hand, refers to one very specific cause of that syndrome. It specifically means the excess cortisol is being driven by a tumor in the pituitary gland.
An adenoma, right?
Exactly, a pituitary adenoma that oversecretes this signaling hormone called ACTH.
Okay, let me make sure I have this straight for everyone listening. Every single case of Cushing's disease is technically Cushing's syndrome.
Yes, exactly.
Because it results in high cortisol. But most cases of Cushing's syndrome are absolutely not Cushing's disease because the cortisol could just be coming from somewhere else entirely.
You've got it perfectly. And, to understand why we even have this confusing naming convention in the first place, we actually have to rewind to 1932.
Okay, taking us back.
Yeah. This is when Harvey Cushing, who was this American neurosurgeon, widely considered the father of modern neurosurgery, actually he published a landmark paper.
Right, and he was looking at a very specific cluster of patients. There was this one famous patient in particular, a young woman they referred to as Mini G.
Right, Mini G.
And she developed this really striking presentation. We're talking truncal obesity, these dark purple stretch marks on her abdomen called striae, excessive hair growth, profound muscle weakness.
Incredibly high blood pressure, too.
Yeah, and easy bruising. And Cushing basically linked all of this to tiny tumors in the pituitary gland that he actually found during surgery or, at autopsy.
And what's truly fascinating about that is the scientific era he was working in. In 1932, endocrinology was barely a field.
Right, they barely knew what hormones were.
Exactly. Most physicians looked at a patient like Mini G and assumed, logically enough, that because the adrenal glands sit on top of the kidneys and produce the hormones causing these changes, the disease had to originate in the adrenal glands themselves.
It makes sense on the surface.
It does. But Cushing proposed something completely radical. He argued that the pituitary gland up in the brain was acting as this master gland.
Right.
And that a tiny abnormality up there was actually the upstream driver of the downstream adrenal problem.
See, okay, that timeline is what really gets me. Let's unpack this for a second. He is deducing the existence of this whole communication network, what we now call the hypothalamic pituitary adrenal, or HPA axis, completely backward.
Totally backward.
And he's doing it decades before the actual chemistry was even understood. The hormone ACTH wasn't isolated until the 1940s.
Right.
And cortisol itself wasn't synthesized in a lab by Merck until, 1949?
1949, yeah.
So he literally described the entire clinical picture and the invisible mechanism 20 years before anyone could actually, measure the hormones responsible for it.
It's honestly an absolute triumph of clinical observation. He just saw the pattern and inferred the biology.
So incredible.
But, to really understand what was happening to Mini G and what happens to patients today, We have to look at how that invisible mechanism that HPA axis is actually supposed to work when a person is totally healthy.
Right. Let's break down that biological circuit.
Yeah.
How does this master switch operate on a normal Tuesday?
Well, it's a very precise chemical cascade.
Yeah.
It starts up in the brain, in the hypothalamus,
Mm-hmm.
which releases a hormone called CRH,
Okay.
and that acts as a signal to the anterior pituitary gland, which is sitting just below it,
Mm-hmm.
telling it to release ACTH. That ACTH then travels all the way through the bloodstream down to the adrenal glands, specifically to this middle layer of the adrenal cortex called the zona fasciculata.
Zone fasciculata. Okay.
Right. And it tells it to manufacture and release cortisol.
And this isn't just like a flat hum of hormones running all day, right? There's a rhythm to it.
Yes, exactly. A very strict diurnal rhythm. Your cortisol levels naturally peak in the early morning.
That's what wakes us up.
Exactly. It's what helps wake you up, raises your blood sugar just a little bit, and prepares you for the stress of the day.
Makes sense.
And then those levels drop very low at night so your body can rest and repair. And crucially, this whole system is governed by a negative feedback loop.
Okay. Meaning what?
Meaning, when cortisol levels rise in the blood, that cortisol loops back up to the brain and tells the hypothalamus and the pituitary, okay, we have enough in circulation. You can stop sending CRH and ACTH.
Oh, it's just like a thermostat in your house. The house gets warm, the thermostat senses that heat, and it just turns the heater off.
That is the perfect way to visualize it.
But in Cushing syndrome, it's like the thermostat is completely disconnected and the heater is just blasting 24/7, and eventually it's going to melt the furniture and burn the house down.
Exactly. The biological loop is broken. Cortisol just keeps being produced or, supplied from the outside, entirely ignoring all the normal suppressive signals from the brain.
So what is that furnace actually doing to the house? Like, what is cortisol's actual day job when it's not melting the furniture?
Well, cortisol is a stress hormone, obviously, but you really have to distinguish it from adrenaline.
Right, because they feel different.
Yeah, adrenaline is for those split-second reactions, like jumping out of the way of a speeding car.
Yeah.
But cortisol is built for sustained fight or flight.
Like endurance stress.
Exactly. We're talking hours of survival mode, like trekking through a blizzard or, historically, outrunning a predator across a savanna.
Okay.
So physiologically, it is catabolic, meaning it actively breaks tissues down.
Yeah.
It is gluconeogenic, meaning it forces the liver to create new glucose for quick energy.
Got it.
And it's immunosuppressive, which dials down inflammation so your body doesn't waste precious energy fighting, like a mild cold when you're just trying not to get eaten.
Right, so it's mobilizing literally every ounce of stored energy you have for immediate survival. But if that's running constantly...
It does all of those things in a highly exaggerated pathological way. It breaks down your muscle and connective tissue just to make more glucose that you don't actually even need.
Oh, wow.
It thins the skin, which is exactly why patients get those purple stretch marks. The collagen is literally degrading.
That's terrifying.
It is. It suppresses your immune system, leaving you vulnerable to strange infections. And at very high concentrations, it even acts like a totally different hormone called a mineralocorticoid.
Wait, what does that do?
It forces your kidneys to hold on to sodium and water, which drives blood pressure dangerously high.
Okay, before we get into how all of that reshapes a person's body, if you're ever reading a medical chart, there is a trap you might fall into here that we need to mention.
Oh, right.
Yeah. Do not confuse Cushing's syndrome with Cushing's triad. They sound totally related, but they are entirely different biological emergencies.
Ah, yes, that is a classic point of confusion for students. So Cushing's triad consists of high blood pressure, a slow heart rate, and irregular breathing.
Right.
But that happens when there is dangerously high pressure inside the skull, usually from, like, severe head trauma or a massive stroke.
And Harvey Cushing described that phenomenon too, right?
He did, hence the shared name. But physiologically, the triad has absolutely nothing to do with cortisol excess. It's just a historical naming coincidence.
Okay, I'm glad we cleared that up for everyone. Let's get back to the physical changes, because when that cortisol furnace runs constantly, the physical manifestation just doesn't seem to make sense.
How do you mean?
Well, if cortisol's job is to break things down for energy, why is weight gain the hallmark symptom?
Ah, you're hitting on the paradox of fat redistribution. This is honestly one of the most visual, defining features of Cushing's syndrome. You see simultaneous wasting and fat gain in the exact same patient.
Right. People often describe it as looking like a lemon on toothpicks.
Yes, that's the classic description.
The patient gets this severe central obesity, a very round moon face, and this prominent collection of fat on the back of the neck, which is sometimes called a buffalo hump.
Right.
But at the exact same time, their arms and legs get incredibly thin because the muscle and the subcutaneous fat are literally just wasting away.
Exactly.
But wait, hold on. That feels like a massive contradiction.
It does?
How does the exact same hormone tell my belly to aggressively store fat, but tell my legs to literally eat their own muscle? Like, how is the signal getting crossed?
It really does seem contradictory until you look at the cellular biology of it all. It basically comes down to regional differences in the body.
Okay.
Cortisol interacts with tissues differently depending on where those tissues are actually located. Visceral fat, the fat deep inside your trunk and around your organs, has a much, much higher density of glucocorticoid receptors compared to the fat in your arms and legs.
Interesting.
Plus, we have to factor in insulin here.
Oh, because of the blood sugar.
Exactly. Because cortisol is constantly dumping new glucose into the blood, the body responds by pumping out massive amounts of insulin to deal with all that sugar.
So you basically have this cocktail of high cortisol and high insulin just swimming around together.
Exactly. And in the central trunk, where those receptors are dense, the interaction between high cortisol and high insulin strongly promotes fat storage.
Oh, I see.
The body thinks it needs to hoard energy right around the vital organs for this never-ending stressful event.
But in the arms and legs.
Out in the periphery, cortisol's catabolic nature just dominates. It actively breaks down muscle protein to turn it into more glucose, and it prevents any new muscle from being synthesized.
Okay, that makes so much sense now. So it's not one single command for the entire body. The tissues are actually translating the exact same hormone signal into two completely opposite actions based on their local receptors.
You nailed it.
Now, while a pituitary tumor is the classic driver of this, there's actually an even more dangerous acute version of this paradox. We need to talk about the ectopic threat.
Yes, this is where things get truly critical. Sometimes the ACTH that's driving the adrenal glands isn't coming from the pituitary gland at all.
Right.
It's coming from a tumor somewhere else in the body ectopically.
Which is terrifying.
It is. The most common culprit is actually a highly aggressive form of cancer called small cell lung cancer, though it can also happen with, bronchial carcinoid tumors or even pancreatic tumors.
And these patients, they don't look like mini G, do they? Like, they don't have that slow onset moon face presentation with all the weight gain.
No, not at all. They usually crash much too quickly for the body to even accumulate that central fat.
Wow.
They present with severe, sudden muscle weakness and profound hypokalemia, which is just dangerously low blood potassium.
Why does the potassium just completely bottom out like that?
Well, because the cortisol levels in these ectopic cases are so outrageously high that they just overwhelm the body's local defense system.
Defense systems.
Yeah. Normally, there's a protective enzyme in the kidneys called 11-beta-hydroxysteroid dehydrogenase type 2.
That is a mouthful.
It is.
Yeah.
But just think of that enzyme like a bouncer at a very exclusive club.
Okay, I like that.
Its job is to rapidly deactivate cortisol so it can't sneak in and bind to the mineralocorticoid receptors, which, as we mentioned, are supposed to be strictly reserved for regulating salt and water.
But because the ectopic tumor is producing just so much cortisol, the bouncer just gets completely overrun.
Precisely. The bouncer is overwhelmed, the cortisol floods those receptors, and it sends this massive, totally inappropriate signal to the kidneys to just dump potassium into the urine and rigidly hold on to sodium.
Oh, wow.
Yeah, and this skyrockets the blood pressure and causes the muscles to basically stop working properly because, they need potassium to contract.
That is wild. But there's another really weird clinical quirk here too, right? These ectopic patients don't just get weak. Their skin actually changes color.
Yes, they do.
They look incredibly tanned even if they haven't been in the sun for months. What is the link there?
That is honestly a fascinating molecular byproduct of how the body manufactures hormones. So ACTH isn't just created out of thin air.
Right.
It is actually chopped out of a much larger precursor molecule called POMC, pro-opiomelanocortin.
Okay.
When a lung tumor goes rogue and starts pumping out massive, unregulated amounts of ACTH, it's also pumping out all the leftover fragments of that POMC molecule.
Oh, I see where this is going.
Yeah, and one of those fragments happens to directly stimulate the melanocytes in the skin, which produce pigment.
So the pituitary, or I guess in this case, the lung tumor, is basically throwing everything at the wall just to drive the adrenal glands. And the skin pigment is really just collateral damage from the manufacturing process.
That's a great way to put it, collateral damage. So the clinical teaching point here is pretty stark. If you see a patient who looks acutely ill, has profound muscle weakness, low potassium, and sudden, unexplained hyperpigmentation,
Right.
you shouldn't be thinking about a slow-growing, benign brain tumor. You should be aggressively hunting for a malignant cancer, most likely in the lungs.
Man. But, here's where it gets really interesting. If we're looking for where Cushing's happens most often today, we actually shouldn't be looking in oncology wards, and we definitely shouldn't be looking at neurosurgery.
No, we should.
We should be looking in people's medicine cabinets. The epidemiological center of gravity has totally shifted here.
It really has. We are talking about exogenous or iatrogenic Cushing syndrome.
Meaning caused by doctors.
Exactly, caused by medical treatment.
Huh.
Look, corticosteroids are basically miracle drugs. They are the most potent anti-inflammatory agents we have. We use them for literally everything.
Asthma, rheumatoid arthritis, organ transplants.
Severe allergic reactions, inflammatory bowel disease, you name it.
And it's not just like taking high doses of oral prednisone pills either. You can get Cushing's from high-potency topical steroid creams used for eczema, or from steroid injections straight into a bad knee joint, and even from inhaled asthma steroids.
Yes, and the inhaled steroids become especially dangerous when they're combined with certain other very common drugs.
Like what?
Well, for example, ritonavir, which is heavily used in HIV treatment regimens, acts as what we call a CYP3A4 inhibitor.
Okay, let's break that down for everyone. Think of CYP3A4 as the liver's garbage disposal for steroids, right? It chops them up and flushes them out of the body.
Exactly. So ritonavir basically unplugs the garbage disposal.
Yikes.
Yeah. Suddenly, a mild, local, inhaled steroid that usually gets flushed out very quickly, enters your bloodstream, isn't broken down by the liver, and just builds up to massive toxic levels in the blood.
And that causes full-blown systemic Cushing's.
It does.
It's highly ironic, honestly. We invented these synthetic steroids to cure inflammation, and in doing so, we are artificially recreating Harvey Cushing's rare tumor syndrome on a massive global scale.
It is ironic, and it creates a very dangerous hidden trap for the patient.
Because of the feedback loop.
Exactly. Because the HPA axis relies on that negative feedback loop we talked about earlier.
Yeah.
When you pump the body full of external synthetic steroids, the hypothalamus and pituitary sense all that glucocorticoid activity, and they just go quiet.
They just shut down.
They stop making CRH and ACTH. The body's internal steroid factory basically boards up the windows, turns off the lights, and goes to sleep.
It's like relying on a food delivery app for a whole year. The food just keeps showing up at your door, so eventually you just throw away all your pots and pans. You literally forget how to cook.
That is a brilliant analogy.
The body forgets how to make its own cortisol. So if a patient gets tired of the medication side effects, the weight gain, the mood swings, the insomnia, and they just decide to throw their pill bottle in the trash and stop abruptly,
they will immediately crash into acute adrenal insufficiency.
which is really bad.
It's catastrophic.
Yeah.
The external supply of steroids is suddenly gone, but their internal factory is asleep. Like you said, it has thrown away the pots and pans.
Right.
It cannot wake up fast enough to manufacture the cortisol they desperately need to survive the day. It is a true life-threatening medical emergency.
What happens to them?
Their blood pressure bottoms out, their blood sugar drops, and they can go into shock. You can never, ever just stop taking chronic steroids. You have to taper the dose incredibly slowly over weeks or even months to coax the brain into waking that axis back up.
That sounds incredibly difficult to manage. And the diagnostics to figure out if someone actually has endogenous Cushing's sound even worse because it's not a black and white picture.
Yeah.
There's this whole gray area called pseudo-Cushing's states.
Yes, and this raises a vital diagnostic question.
Yeah.
How do you know if a patient's elevated cortisol is being driven by an autonomous tumor or if it's just the body having a natural, totally appropriate reaction to severe stress?
Right, because stress is stress.
Exactly. Pseudo-Cushing's states happen in people with chronic alcoholism, severe depression, extreme obesity, or poorly controlled diabetes.
Okay.
These conditions place such a heavy physiological and psychological burden on the body that they just naturally elevate cortisol.
And they can even cause some of the physical signs, right? Like the central obesity and high blood pressure, without there being a tumor at all.
Absolutely.
It's a diagnostic minefield because metabolic syndrome and type 2 diabetes look an awful lot like Cushing's on the surface. So you can't just draw a single tube of blood, see high cortisol, and schedule them for brain surgery.
Never. Never do that. Cortisol secretion is highly pulsatile. It naturally goes up and down throughout the day. I mean, it will spike just because a patient is stressed about getting their blood drawn.
Oh, sure, white coat syndrome.
Exactly.
Yeah.
So diagnosing Cushing's requires a rigorously layered biochemical approach. Step 1.
Yep.
You have to definitively prove there is actually excess cortisol over time.
And how do you do that?
You don't do this with a single blood test. You do it with a 24-hour urine collection to see the total daily output, or you test their saliva late at night when their natural levels should be near zero.
Or you do the dexamethasone suppression test, which is fascinating to me.
Oh, that's a classic test.
You basically give them a tiny dose of a potent synthetic steroid at like 11 p.m. and then check their blood the next morning.
Right.
And if their HPA axis is healthy, that tiny dose should trigger the negative feedback loop and shut down their morning cortisol spike. But if their cortisol is still high the next morning, you know the loop is completely broken.
Precisely. You prove the leak is ignoring suppressive signals. So that's step 1. Step 2 is determining if this excess cortisol is ACTH dependent or independent.
Okay.
You measure ACTH in the blood. If it's nearly undetectable, the adrenal glands have gone rogue and are acting on their own, which is usually an adrenal tumor.
Right.
But if the ACTH is inappropriately normal or high, something upstream, like the pituitary or a lung tumor, is driving the adrenals.
And only then, after all that biochemistry, do you actually go looking for the source with imaging. And honestly, the lengths doctors have to go to just to find these tumors are extreme.
They really are.
Like, what happens if the blood work points to the pituitary, but the MRI of the brain doesn't show anything? Because these tumors can be microscopic, right? Just a few millimeters wide.
Yeah, that happens a lot. When the MRI is negative but the biochemistry points to the brain, endocrinologists rely on a procedure called inferior petrosal sinus sampling.
This blew my mind when I read about it.
It is incredibly invasive but brilliantly logical. An interventional radiologist threads tiny catheters up from a vein in the patient's groin all the way up through the chest, the neck, and into the skull.
Just navigating all the way up there.
Yep, stopping in the very specific veins that directly drain the pituitary gland. They then measure the ACTH right at the source, before it dilutes into the massive volume of the rest of the body's blood.
That is insane.
They even compare the left side of the pituitary to the right side to tell the neurosurgeon exactly where to cut.
It just shows you how delicate and interconnected this endocrine web really is. And historically, attempting to surgically fix these pathways without fully understanding that web, it led to some devastating failures.
Oh, it did.
We have to talk about Nelson syndrome.
Nelson syndrome is honestly one of the great cautionary tales in the history of endocrine surgery. We have to remember what medicine was like before we had these delicate neurosurgical techniques to remove microscopic tumors from the pituitary through the nasal cavity.
Right, they couldn't just go in and pluck it out.
Exactly. Doctors in the mid-20th century faced a desperate situation. A patient's body was rapidly being destroyed by cortisol, and they knew the adrenal glands were the ones producing it.
So to stop the cortisol, surgeons would just go into the abdomen and remove both adrenal glands entirely. Bilateral adrenalectomy.
It seemed like a totally logical fix at the time. Remove the downstream factory, and the cortisol levels immediately dropped to zero.
See, it's like putting duct tape over the check engine light on your dashboard, only to have the engine explode 5 miles down the road.
That is exactly what happened. They removed the factory, but they left the upstream pituitary tumor behind in the brain. And remember that negative feedback loop.
Yep, the brain needs it.
Yeah, the pituitary tumor had actually been partially held in check, slightly suppressed, by those massive levels of cortisol. Once the adrenal glands were surgically removed, that biological brake was entirely ripped off.
So the brain is still screaming for cortisol, but there are no adrenal glands left to answer the call, so the tumor just goes absolutely wild.
It grew aggressively, entirely unchecked. The tumors would expand, compressing the optic nerves and causing vision loss, all while pumping out astronomical levels of ACTH.
Wow.
And because of that POMC byproduct we talked about earlier, these patients developed extreme dramatic skin hyperpigmentation alongside all the dangers of an expanding brain mass.
That is tragic.
It is. Nelson syndrome taught the medical field a brutal lesson. You cannot just surgically treat a downstream gland and ignore the upstream biological driver. The feedback loops will always win.
To really solidify how all of these different pathways interact, I think it helps to map out the neighboring conditions. Like, if Cushing's is the disease of too much cortisol, what does it look like when the exact opposite happens?
The exact physiological mirror image of Cushing's is Addison's disease.
Hmm.
This is primary adrenal insufficiency, where the adrenal glands are destroyed, usually by an autoimmune attack,
Okay.
and they can no longer make cortisol or aldosterone.
So where Cushing's gives you central weight gain, Addison's gives you profound, dangerous weight loss.
Quite.
And where Cushing's drives blood pressure sky high, Addison's causes blood pressure to just bottom out, making patients dizzy and prone to fainting.
Exactly. And interestingly, because the adrenal glands are failing in Addison's, the brain pumps out massive amounts of ACTH trying to stimulate them.
Oh, so they get the pigmentation too.
Yes. Addison's patients also get that striking hyperpigmentation we discussed, just like the ectopic lung cancer patients or the Nelson syndrome patients. Comparing Cushing's and Addison's side by side is honestly the absolute best way to intimately understand everything cortisol does in the body.
You also have to rule out other tumors that can hide in the adrenal glands and cause similar symptoms, right? Like Conn syndrome.
Yes, Conn syndrome is an overproduction of aldosterone, not cortisol.
Okay.
Aldosterone's only job is to trade potassium for sodium in the kidneys. So a patient with Conn's will have treatment-resistant high blood pressure and very low potassium, which mimics some forms of Cushing's, but they won't have the weight gain or the skin thinning.
Right. And then there's a pheochromocytoma.
A pheochromocytoma is a tumor in the inner core of the adrenal gland that secretes pure adrenaline.
Which is very different.
Very different. This causes wild episodic spikes in blood pressure, panic attacks, and sweating. It's an adrenaline rush that won't stop, which feels very different from the chronic, exhausting metabolic grind of high cortisol.
Sorting through all of these overlapping symptoms is just a massive puzzle. But understanding this physiology hasn't just given us cautionary tales, it's actually given us a modern pharmacological toolkit.
Yes, thankfully.
Like, if surgery isn't an option, or if we need to quickly protect a patient's body from the cortisol while waiting for surgery, how do we actually stop it medically?
Well, our modern drugs target specific steps in this exact pathway. For instance, we have glucocorticoid receptor antagonists, like a drug called mifepristone.
So instead of stopping the cortisol itself, mifepristone basically puts earmuffs on the body's tissues. The cortisol is still circulating, but the cells just can't hear the signal, so they stop breaking down muscle and storing fat.
Precisely. It
Yeah.
blocks the receptor. On the other hand, we have steroidogenesis inhibitors like ketoconazole or metirapone.
Okay, what do those do?
These drugs act directly on the adrenal glands. They basically walk into the adrenal factory and shut down the biochemical assembly line so the cortisol just can't be manufactured in the first place.
Okay, so what does this all mean for you listening to this in the real world? Like, why did we just spend this much time dissecting the intricate details of a neurosurgeon's notes from 1932?
Because Cushing syndrome is effectively a grand natural experiment in what chronic, high-dose steroid exposure actually does to human biology.
Wow.
And with millions of people taking corticosteroids for asthma, autoimmune diseases, and chronic pain, this physiology is playing out everywhere, every single day.
It really is.
If you or a loved one takes these common medications, you need to recognize the physical changes. You need to understand why athletes who misuse anabolic or corticosteroids face such catastrophic long-term risks.
Yeah.
And you absolutely must understand why those slow tapering protocols are literally life-saving. Because untreated severe cortisol excess ultimately leads to rampant cardiovascular disease, overwhelming infections, and death.
It's incredible to think about. We started by imagining your body's survival arm, the one meant to save you from a predator on the savannah getting stuck in the on position, melting the furniture to keep the furnace burning.
Right.
But when you look at how we treat inflammation in modern medicine, we are often the ones forcibly flipping that switch.
We are. It leaves you with something profound to consider. Our bodies evolve this incredibly elegant, tightly regulated cortisol loop over millions of years to handle brief, acute survival threats.
Just short bursts.
Right. But now, through modern pharmacology, relentless chronic psychological stress, and synthetic steroids, we are essentially hacking our own ancient biology.
Yeah.
And as our medical interventions become even more advanced and powerful, it makes you wonder, how much further can we push these ancient evolutionary feedback loops before the human body simply loses the ability to regulate itself at all?